because you might very well need.
Hello. Hello. 1, 2. Testing 1, 2. Testing 1, 2. 1, 2. Testing 1, 2. Hello. Testing 1, 2. 1, 2. Remember, it's on number 5. Yeah. 1, 1, 2. 1, 2. Oh.
Pleasant good afternoon to all, and welcome to this, our first year in review and long service award ceremony of the Dominica Hospitals Authority. Welcome to all here, and welcome to those listening on the social media. This afternoon, we want to share with you the results of our stewardship for the last year, and to share with you some commitments and plans and programs for 2022. Before we get into this evening's proceedings, we'd like to invoke God's presence here this afternoon, and we invite Departmental Nurse Mary Bonnet to lead us in a word of prayer.
Almighty and eternal Father, we'd like to thank you for today. We'd like to thank you for life. We thank you for our strength. I ask you, Lord, to just bless every one of us here in this place this afternoon, and more so our retirees. I thank you, Lord, for sparing their life that they can see their appreciation and their word for today. In your name I pray, amen.
Thank you. Thank you, Nurse Bonnie. Mr. Kent Edwards, Acting Minister of Health, Wellness, and New Health Investment. Mrs. Jennifer Astafan, Chairperson of the Dominica Hospitals Authority. His Excellency Elude Williams, Deputy Chairperson of the Dominica Hospitals Authority. Other members of the board here this afternoon, and I want to recognize them. We have Dr. Donald Peters, member of the board, and is also the chair of our clinical committee. We have Mr. Jeffrey Batiste, who is a director and is also a member of the Finance and General Purposes Committee. We have Mrs. Bellot, who is also a director and chairperson of our Human Resources Committee. Welcome, members. I'm so happy that you're here this afternoon. Right? Yes, I'm going through the listing. So, Mrs. Letitia Lestrade-White, Permanent Secretary, Ministry of Health, Wellness, and New Health Investment. Dr. Ruby Blah, our Hospital Medical Director. Ms. Emmeline Matthew, Matron of the Dominica Hospitals Authority. Mrs. Nicole Laville, Director of Engineering Services. Mrs. Doreen Fabian, Facilities Manager. Senior Management of the Dominica China Friendship Hospital, senior nurses and staff, our awardees, persons listening on social media, members of the media, ladies and gentlemen, good evening. This evening, your Dominica Hospitals Authority will host its first annual year in review and long service award ceremony. It is also the first year that a long service award ceremony will be held here at the Dominica China Friendship Hospital. This event will be delivered in two parts, or two segments. The first provides an update to the public on the highlights of our work and achievements during the year, and our commitments, plans, and programs for 2022. During our second segment, we are taking the opportunity to recognize the services of a number of staff who have retired or are about to retire this year. They have all made significant contributions to the development of the Princess Margaret Hospital, now renamed the Dominica China Friendship Hospital. Well, some may ask, why such an event? It's very simple. Our board is committed to not only raising the bar on the overall operations and management of hospitals, but is signaling a new vision for hospital governance, public leadership, and openness and accountability to the public we serve. It is through such an engagement that we can enlighten the public on the operations of the Dominica Hospitals Authority and receive their feedback on how we could better serve them. So to start this evening's proceedings, I now invite the chairperson of the Dominica Hospitals Authority, Mrs. Jennifer Estefan, to deliver opening remarks on behalf of the board. Mrs. Estefan.
Good evening. Thank you, Chairman.
Thank you.
Honorable Kent Edwards, Acting Minister, Permanent Secretary in the Ministry of Health, members of the board present, and those who are not able to attend, senior executive team of the hospital. My opening remarks are going to be very brief. First of all, I would like to commend the executive team for this effort. I believe it's signaling, as you said, a new arrangement and a new governance arrangement for the hospital. We've had our challenges, we've had our concerns. We have members of the public who have their own concerns. But I would like to say to the members of the public that we are looking forward to new experiences at this facility. And I would want to say that today was indeed very heartening. I listened on DBS radio to a program that had to do with quality and service in this country. And it was indeed very heartening to hear that as the year is closing, one of the patients who recently had an experience at this facility chronicled a very positive event, which is what we would like to ensure continues beyond today. She spoke of her experience from the beginning to the end of her admission. At her admission, she spoke about her experience with the reception desk and how positive and how well she was assisted by the person at reception. She followed the steps, and then she chronicled her experience with the cashier, who went way beyond her cashing responsibilities, and she said actually came out of her cashing cage and helped her. She spoke of her experience on her admission on the ward, her experience with the nurse who went in detail on what she should expect while she was a patient at the hospital, and the doctor. And because she mentioned the names, and I've said who they are, I would like to say that she did say that Nurse Laville and Dr. McIntyre were indeed the two persons during admission who made her feel that whatever her experience and her surgery was going to be, she had no fears after speaking to them. And I must say that I wish to commend the staff for this. This is the experiences that we would like the public to have. And so tonight, I can say to the public that this is the experience we expect every member of the public after today will say. Of course, there will always be something that when an individual who is not well comes into an institution, their emotions are heightened, and small things become big things, and we all know that, and we all have to keep those things in mind. But the compassion, the caring, the commitment, the communication and experience this patient chronicled on the radio this morning moved me to a point where I felt that we are beginning to see what should really be happening at this institution, and I commend those who have done it. And without much ado, I would like to congratulate and thank those persons who have, over the years, given their service to this institution, who are now retiring. It would have been for them, they would have straddled, maybe, some of them. I'm not sure what the range of service years would have been. 15, 20, 30, they would have gone from the Princess Marigot Hospital. They would have experienced a bit of history, to the old facility being torn down, to the new facility and the construction, and they would have experienced these difficulties during their tenure here. And we apologize, but wish them well. And so without much ado, I congratulate again the executive team for putting this effort together, and I look forward to many more. Thank you.
Thank you, Chairperson, for that reflection on what appeared in the media today. And a lot of what we've been speaking to this afternoon is how we could impact the patient care experience now and going forward. So without further ado, we will then move right into this afternoon's event, which will involve a discourse between myself and my colleagues to share with you the achievements, plans, and programs for 2022. Thank you very much. Areas that you manage and who you are, starting from my immediate level.
Good afternoon, Dr. James. Good afternoon, distinguished guests, colleagues, the media, and members of the public who joined us this afternoon. I am Ruby Blah, is first and foremost obstetrician gynecologist, but also the hospital medical director. And under my duties would come essentially the supervision of medical staff, primarily medical doctors, as well as an overview of, or provide an overview of, or supervision for clinical services that are provided at the hospital.
Thank you.
Good afternoon to everyone present, invited guests, colleagues. I am Emmeline Matthew, active matron of the Dominica Friendship Hospital, and overall responsibility of supervision of the entire nursing staff.
Pleasant good afternoon to our invited guests, the media, members of the public, and my colleagues. I am Doreen Fabian. I am the facilities manager, and I'm responsible for the support services.
Good evening, all. Good evening to the media, the distinguished guests, my colleagues, and the listening public. My name is Dominica Joseph Hogan. I'm the quality manager. I love people. Everything I do here is for people. I come to work every day because of my love for people. And what I do is to manage complaints, incidents, and to design quality improvement plans.
All right, good evening and season's greetings to everyone. My name is Nicole Laville. I am the Director of Engineering Services, newly appointed to this esteemed team. I have responsibilities for infrastructure maintenance and redevelopment, as well as equipment maintenance and development. Thank you.
Thank you all. So relax, have a conversation this afternoon. It's not an English exam, so just relax yourself and be at ease. Perhaps a good starting point is to hear from medical services on what has happened over the last year. We are trying to refocus this hospital towards an evidence-based practice. I'm sure the public will want to hear about utilization and access issues to the hospital. Dr. Black, can you outline for us sort of the package of services we currently provide to the Dominican public and share with us the kinds of utilization data that we've been able to accomplish during the year.
Thank you, Dr. James. I must say that 2021 has been a very challenging year. We've had additional pressures put on us by or due to the COVID pandemic. And in addition, we continue to practice within or on a site that is essentially still a construction site. And so there are a number of challenges that come out of those two circumstances. However, I still believe for most part we've been providing excellent care to our patients. We provide care in a number of clinical areas, general surgery, and we have a number of specialties, nephrology, ENT, orthopedics, general surgery, urology, internal medicine, obstetrics and gynecology, pediatrics, radiology, psychiatry, A&E services, anesthesia and ICU services as well. So we have quite a large range of services that we provide to the public. And yes, as I said, this year was really extremely challenging. However, when we reviewed our figures, you will see, I'm sure you will agree with me, that quite a bit of work has been done over the last 10 months, 12 months. Take, for example, if we look at figures coming out of the outpatient department, we saw in excess of 30,000 patients. We had about 6,000 inpatient admissions. In A&E, we had about 14,500 patients going through our doors. We did in excess of 8,500 imaging studies. And for those who may need a little bit of a reminder, we provide in radiology or the X-ray department, as it is commonly known, plain X-rays, ultrasounds, CT scans, and we also have special studies like contrast studies. We also have 31 patients currently on hemodialysis, and we've done over 800 surgeries. Now that is in the context of having interruptions to non-emergency surgeries due to COVID, as well as the period of time when we were moving from the old location of the theater to its current new location. We've delivered up to date 815 babies, and the physio department provided care to over 4,800 patients in the course of this year. So I'm sure you will agree that we've done quite a bit of work. I would like to take a closer look at the results out of the accident and emergency department, because that is obviously, I guess you could refer to it almost as a flagship department for the hospital. And just to put things in context, when a person comes into the hospital through A&E, a triaging process takes place where they're quickly assessed, and it's based on a scientific process to determine just how sick they are, and that in turn determines what must be done for them, how quickly it must be done. And this triaging has 4 categories, where one is your most critical, your really sick patients with life-threatening conditions, and that moves through 2, 3, and 4, where 4 are really or less urgent cases. And in a number of situations, 3 and 4 patients could probably be seen elsewhere outside of the emergency setting. And if we look at just November as a snapshot for the rest of the year, we will see that just about 0.2% of patients were assessed as being in category 1. Now, this is an emergency department that we're speaking to. And quite, I guess, would be shocking for some persons, 70% thereabout of patients fell in category 3 and 4. And as I said before, those are patients who probably could be seen in other settings. The thing is, when patients who are not dire emergencies come into the emergency room, they can take up time, resources, human resources including, that probably might be better used taking care of the true or more sick patients, let's just put it that way. And so this is obviously something that we need to pay attention to, and a little later, we're going to look at some approaches that we have in mind as how we could address the situation. A good measure of performance as well is in average length of stay and percentage occupancy. And we look at the medical wards and we see that patients spend on average about 7 days, and the occupancy levels are up to 72%. The surgical wards, they spend about 6 days, with the occupancy percentage levels being about 67%. Labor and delivery, 4 days, 32% occupancy. The pediatric service, including neonatology, almost 5 days, just about 5 days, 27% occupancy. The ICU, that's the intensive care unit, a little under 5 days, 43% occupancy. Psychiatry, because of the nature of psychiatry, patients tend to spend a longer time. So we're looking at almost a month, about 26 days.
Right.
And we have a fair percentage in terms of occupancy, 61%. And again, persons familiar with the specialty will recognize that the psychiatric patients tend to need a bit of a longer stay. And finally, our ambulatory care unit, where essentially people come in just for the day, usually to receive some type of surgical procedure. So we don't expect them to really spend much more than a day unless there's some kind of issue or complication and they end up getting admitted for longer stay. So obviously the average length of stay was just about a day, and our percentage occupancy just under 10%.
But I've been looking at some data from Moody's. As you know, Moody's is an agency in the US that provides data on various industries. And Moody's speak to, has provided information on hospitals that are high performing and are not for profit. They provide guidance on lengths of stay and occupancy levels. And they recommended that high-performing hospitals, lengths of stay range between 4.9 days and 5.6 days. Occupancy levels are about 67 to 75 days. How does the hospital match up with those kinds of indicators?
So based on the figures that I just presented, you see we actually match up quite well. There are probably some concern areas, if you want to call it that. We spoke about psychiatry already, which falls outside of this range. The medical wards, medical services, we do see that patients spend on average about 7 days. So that really confirms this, I think it's been referred to as an epidemic. The issues that we're having with NCDs, the high blood pressure, diabetes, those are the main conditions getting patients onto the ward with strokes and heart attacks. And so this just raises a red flag that we need to have more discussions as a country, and certainly we need increased collaboration between the hospital and primary healthcare services as to how on a national level we're going to deal with those issues. Wow. In terms of the surgical cases, conditions, again, such as amputations or patients with diabetic feet will also usually increase their length of stay, but this ties in very much with what we just spoke about in terms of managing our CNCDs. And services such as ambulatory surgeries will also help to decrease the length of stay for surgical patients. So again, that's one of the areas we can look to do more work in and provide greater service so that we are able to decrease the length of stay for surgical patients.
I want to switch to quality because we get a lot of concerns from the public about frequent cancellations of surgeries, all right? And I don't know if that is coming through your site. What are you seeing there with respect to cancellation of elective surgeries? What is happening there?
We have quite a bit of issues concerning the cancellation of elective surgery. One comes to my mind, and there's this 80-year-old patient that I'm actually assisting. He has to do some kind of elective surgery. And when he came in, he was scheduled for surgery, and everything went well. But the time he came in for admission on the Sunday, when he came in for admission, he could not get admitted. Why? Because there was no bed space. So when I went in and I did investigations and so forth, I found out that there were admissions on the weekend, and the patients that had to be discharged were not well enough to be discharged. So there was this issue of bed space. So he had to go home and get another date for surgery. So that is one of the reasons why our electives list, we have a backlog of elective surgery. Another one of the things that we see besides the resource constraints that we have, we notice that patients, for elective surgeries, well, first thing, we've had to suspend some of our elective surgeries because of the COVID-19 pandemic. And the reason why we've had to do that is because the operating theater could only accommodate for a particular amount of time just our emergencies. We have also seen, so that has contributed to the backlog. We have also seen that patients who come in for elective surgeries, those emergencies take precedence over elective surgery. So let us say there's a list for elective surgery and a patient comes in with an unforeseen amputation. This case will be taken before the elective surgery. So it will create a backlog of elective surgery. Another thing we've seen is when patients come in with malignant tumors or cancers, those kinds of emergencies, the surgeons will actually do those emergencies first before the elective surgery. So you find that persons have to wait a longer period of time to have the elective surgery.
All right, I'm hearing you, but somewhere in the conversation later on, I want to hear what steps are going to be taken to address those, because if we leave them too long in an elective state, they soon will become emergencies. So somewhere in the conversation a little later on, we have to be able to prefer a response as to how we're going to address those cases. I want to switch to matron now. We've locked down this place to open visitation, but we've had to exercise a sense of sensitivity for patients who are in a particular condition. Can you share with us how we have adjusted the visitation policy to accommodate certain categories of patients?
Thank you, Dr. James. A pleasant good afternoon again to my colleagues invited here. As you know, due to the advent of COVID, we have adopted a no visitation policy. However, we have listened to the public, and the management team met, and we had to go over our visitation policy. Now, we realized that persons out there wanted to know what was happening to the critically ill patients at the hospital and those who were at near end of life. So we implemented a policy where that everyone who has that category of patient would have to have an antigen test done before coming to the hospital. And when you come in, you will be allowed 15 to 45 minutes to spend with that person. However, we are getting good commendation from the public. Then we realized that the patients who were admitted to the maternity unit, we listened to the cries of the significant other and the husbands more specific, and we implemented the same policy where you have proof of your antigen test, you come in, and that person will be allowed to go into the labor ward, but during the active phase of labor. And I think the public, from all records, we realize that they are very pleased with this.
Yeah. Thank you very much. More of that needs to happen to show that level of sensitivity to the concerns of the public. The more we listen to our public, is the more we'll be able to make the changes required to satisfy the concerns that they have. I want to switch to engineering. The government is making quite a significant investment in health facilities, and specifically in the case of hospitals, in excess of $40 million in new construction and in some instances upgrades to the Dominica China Friendship Hospital and new technology. Construction work started somewhere around August 2016, and a number of buildings have been constructed and new services implemented. Can you enlighten us on the phases that have been completed and the types of installations that we now have at the hospital?
All right, thank you, Dr. James, and good evening again to everyone. Dr. James, I'm very pleased to have this opportunity to speak to the development and the launch of the Dominica China Friendship Hospital, which is very evident by the redevelopments and the new installations. So I want to highlight some new installations that we have. We have commissioned 4 new buildings, which include the expanded and updated accident and emergency department, which includes a triage room, a larger waiting area leading to the doctor's offices, a separate section for treatment, a trauma room, and even an operating theater for emergency surgeries. We have an updated laboratory, and we have the updated what we call radiology or diagnostic imaging department, where we have the digital X-ray, HIFU, CT scans, MRI, the newly commissioned MRI, and other imaging equipment. We have updated an outpatient, newly commissioned outpatient eye clinic, also with its own operating theater. We have an operating theater suite, complete suite with 4 operating rooms. And this takes the number of operating rooms at the hospital to 7 operating rooms at the hospital. We have an 8-bed ICU, inclusive of 2 isolation rooms. We also now have an oxygen bank, which supplies piped oxygen to the ICU as well as to the operating theater. And all of these are necessary infrastructural developments that had to take place in order to support our medical personnel and to provide quality patient care in this age. We are also nearing completion of our 2 new inpatient buildings, which will house the surgical and medical wards, gynecology and obstetrics, pediatric ward as well, and that will increase our bed capacity, so hopefully we'll have less of the problems that Mrs. Hogan and yourself spoke about. Currently, for these new buildings, the superstructure is completed. We have installed windows, doors, and elevators. And right now, the contractors are working on the finishings. And we hope to see the completion of these buildings very soon.
Thank you. Thank you very much. It's quite a bit of installation. How you hope to maintain those equipment?
In terms of the equipment, and I will speak to that later, we hope to have a robust maintenance, preventative maintenance program, which the hospital has committed to investing in a robust preventative maintenance program, also a number of maintenance service contracts as well, so that we can improve the uptime of all of the equipment and make it available for our medical personnel and for all of the public to use.
Right. Well, I'm happy to hear that. Certainly the language that you're using about uptime and is clearly linked to Dr. Bla's area, because if you keep the equipment at a high percentage of in good working order, then we could talk about sustaining medical services.
Exactly.
That's good. Thank you very much for that. Let me switch now to quality. The public knows very little about the quality department, its work and the importance to improving services at the hospital. Tell us what this department is all about and the work it has been able to do over the last 5-6 years.
Well, Dr. James, you know I can take the whole day to speak.
Well, you don't have the whole day, because you got some folks in the back reading the collective thing, so
So I'll
go
be
ahead.
brief. Well, the quality department is a patient-centered department, and everything that we do is for the well-being of the patient. I can think of a few of our responsibilities. We manage complaints, and when we receive a complaint, within 5 working days, we acknowledge the complaint. And we try to investigate and close off within 20 working days. And so, for the year, we've had about 46 written complaints. And those areas that people complained about were WD ward, A&E, OPD, and IMRI ward. I just want to let people know how they can lodge a complaint. You can lodge a complaint in 3 ways. You can do that face-to-face. So if you're at the hospital and you encounter some kind of problem, or you are dissatisfied with a service, you can come up to the quality department and speak to us. You can also lodge a complaint through writing. So you can write a formal letter addressed to the quality manager, Dominica Hospital's authority, or you can write an email. Send us an email at pmhqualitydepartment@dominica.gov.dm. You can also call us. You can call us. You can call us at 266-2019, 266-2183. And so these are the ways that we can lodge complaints. And again, we encourage persons to come out and complain, because we cannot fix without critics.
You have to copyright that.
Yes. We cannot fix without critics. And
So I'm hearing you, but tell me something, right? How are you assuring the public that the future care will not be compromised by making a complaint?
Because, Dr. James, it is human to err. And when persons complain, it doesn't mean that the nurse, because they tell you, Mrs. Hogan, I don't want to say anything because I don't want the nurse to lose her job. I don't want the doctor. But that's not what we are about. We are not here to mete out punitive measures. We are here to find out what happened. Look for the systematic errors. Find out what happened, why it happened, and how we can learn from them. We are not here for persons to lose their job. No, that's not what we're about. And so we want to encourage persons to report, be truthful, report. We just want to know what happened so that we can fix the problem. And this organization is a learning organization, right? We learn and we fix, right?
Well, you tend to be very convincing at times, but I have to say I agree with you on that one. We have to put things in place to give the public the assurance that it's quite okay to complain. We want to hear from you. Don't judge the hospital on social media. Give us an opportunity to hear from you and be able to fix it. But later on, I want to hear from you the kinds of systems we'll put in place to assure the population that they can feel comfortable to make complaints, and not feel that the future care would be compromised.
And Dr. James, I also want to speak briefly about our incident reporting. And so, I don't want to take much time, I said, but about our incident reporting. Normally, staff report incidents. And so, when we receive an incident, we grade and manage the incident based on severity, right? And then for the year, we've had about 163 written incidents. And some of the incidents came from areas like Stronach, Operating Theatre, and Alford Ward. And so when we look at the amount of incidents that we had for the year that was recorded, 163, I don't know if you remember the time when we calculated the amount of incidents that we are supposed to be recording for the year, based on the size of the hospital, the number of employees, and the number of hours that we do. We found that we should be reporting in excess of 2,000.
Yeah.
So if you do the maths, we got 163 incidents, recorded incidents, and we're supposed to have 2,000. So it shows that we are under-reporting. So I'd like to encourage staff, please, report. Report, and a little later on we'll speak about.
Right. Yeah, that's an interesting observation, because it is something new. So we have to move towards promoting incident reporting. We have to try to create a just culture by saying to staff, look, it's quite all right to report it. We need to know what has happened, because one of the functions of the board is risk management. And so if we understand what our risk profile looks like, we are able now to take mitigation steps very, very early. So it's an interesting observation. We've got to find a way now of getting staff comfortable that reporting incidents is not to be punitive, but is to understand what has gone wrong, understand our risk profile, and then mitigate it. Thanks very much for that intervention. I want to switch to support services now. You seem very uneasy, so let me make it easy for you. We sometimes undervalue or take for granted the important role that support services in a hospital play in maintaining a safe environment of care. From daily cleaning of public bathrooms and floors, patient transportation, meal services, sanitization of clinical and non-clinical spaces, to simply booking appointments and billings for services. As the manager responsible for support services, could you highlight the major changes which have taken place in the management of support services this year?
Good afternoon again, and Dr. James, you are quite right. Sometimes the work of the domestic staff is undervalued. However, let me just encourage us as managers to continue to show and to tell them how important the work that they do is. They play a pivotal role in maintaining a clean and safe environment for the staff and the patients and the public as well. I must admit, yes, our footprint is larger. The hospital is growing in leaps and bounds. Therefore, it requires a different approach to the many services that we provide. We cannot continue business as usual. DES, Director of Engineering, just mentioned that soon to be completed is our 2 4-story building. Therefore, when we looked at what we had with the domestic staff, we decided to implement a 12-hour shift system. So we would have domestic staff work from 7 a.m. to 7 p.m. in the evening, and then 7 p.m. to the next morning. Because of this initiative, we were able to free up some staff that we could assign to the dietary department. I will talk a little about it in a while. Let me tell you, the domestic staff, the night staff prior to this initiative, we never had cleaning staff in the evening. So this initiative, we have cleaning staff, and their responsibility is to ensure that all spills are taken care of on the wards, as well as to provide ongoing services to the accident and emergency department. Food servers. We were able to assign 8 staff to the dietary department to serve as food servers. And the responsibility for the food servers is not only to place the plate and turn their back and go. We encourage them to have a little discussion with the patients. And so far, they have been doing it, and what we have seen is we have less waste. Less food is going down in the bin. So we want to encourage them to continue to speak to the patient, let them feel comfortable, have a little discuss. Sometimes that's all it takes, and then they would appreciate what we have. We have been operating, as you have heard from all the staff, on a construction site. However, we continue to put the patient or the public first. Services has never been compromised, and we try our utmost. Nevertheless, there are sometimes some areas that the patients were uncomfortable with. For example, elective surgery. You come and do an elective surgery. In times past, then we would send you north, then we send you south, then we would send you east. What we have done is create a more patient-centric environment. So, in other words, we created a one-stop shop. So when the public comes in, we located the admission clerk, the cashier, and the appointment clerk in one common location. And this area, the public has easy access. They can transact their business in privacy. And I must report that we are getting good feedbacks. It is working very well. So too are we have very little complaints with the night staff, even the 12-hour shift with the domestic. In the beginning, yes, they were complaining because it was a new initiative, but now they're enjoying it. They work 2 days in, they go home 3 days, and it is working, and we look forward to, just encouraging them and continue working with them.
Yeah, I really have to commend you on that one, because this is a case where a simple system change towards 12 hours shift has freed up resources so we could have repurposed those resources as food servers. And not only that, we've now seen plate waste have declined. That is a whole piece of efficiency that has taken place there, because sometimes we tend to just bring on more and more and more staff to address issues. But this is a case where a change in the working hours has brought about some additional staff, to free up some additional staff who were then reassigned to do some work that improved customer service. Really, really, really good initiative.
So Dr. James, tell us a little bit about your service. You serve as an ex officio member of the Dominica Hospital's authority board, and we want to know, without breaking confidentiality, tell us a little bit about the workings of the board. How are they settling?
I'll respond, but it doesn't absolve you from responding to how we're going to deal with the electives later on. All right, so our board has been installed on the 1st of August. As I mentioned earlier on, our chairperson is no other than Mrs. Jennifer Astafan. As the chairperson, His Excellency is deputy chairperson and also chair of our finance committee. Other members include Ms. Joan Bellot, who is here with us today, Dr. Cyril Robinson, Dr. Gail Defoe, Mr. Jeffrey Batiste, who is here with us as well. Dr. Donald Peters is the chair of our clinical committee, and Mrs. Colin Felix Grant is also a director on the board. Well, the board really hit the ground running, for want of a better term. We had to establish board committees, 3 board committees according to the law. A finance committee, clinical committee, and a human resources committee were established. We had to develop terms of references for these committees and assign persons responsible for leadership of those committees. Well, no sooner as the board was installed, they had to address a number of what I consider to be big policy issues. We had to address the question of the special risk allowances for staff. We had to address the phased commissioning of Marigot Hospital. We've already had some meetings with staff. We had to address the question of fees for MRI services. We've had to address fees for the use of our operating theaters. Right? So they have been dealing with a lot of big policy issues, all in an effort to begin to drive the changes within the hospital. On the corporate side, we've had to set up our own bank account to receive subventions from the government, put signatories in place. Today, we now write our own checks here at the hospital. So I can assure you that from August to date, all the suppliers that we've engaged over the period of time, their billings are all current. As a matter of fact, all our farmers today are extremely happy because there's no wait time for them to get payments for supplying the hospital with produce. So all in all, it has been a very busy time for the board. We haven't yet completed our orientation of members, and members are committed to making a difference to the lives of the population.
Dr. James, earlier you asked me about how am I going to maintain my equipment, our equipment. So now I want to ask you this question. I know you've been looking at our billings, collections, and exemptions. Can you tell us how performance has been thus far at the hospital?
All right, I just want to, let me preface it by saying that there is the perception that since the authority that we've privatized services. This is far from the truth. There's no privatization of services. All that has happened is that a new governance arrangement is put in place to improve the performance and management of the hospital. That's the first issue I'd really like to raise. The fees that we currently are required to adjudicate are fees that are on the statutes are referred to as the statutory rules and orders, 2021. So the fees haven't changed under almost a decade. When we look at our data on billings, collections, and exemptions, we've billed close to $1.8 million for the year. And this is billings for the current year. We've collected all told about $2.1 million, and we've provided exemptions just over $1 million. So when the issue of access came up a couple of weeks ago, and access to care, etc., clearly you see the numbers. We've provided exemption to persons of close to $1 million. It doesn't mean that the debt is forgiven. The debt is not forgiven. But what we have done is to provide the care, and then the invoice will then follow the patient. So we have to follow up on those exemptions to make sure that the monies we collect can help you with your preventative maintenance program. All right? But all in all, I think we've done a fairly performance in terms of our collections was good. I have to commend the public for, even in difficult times, have seen it fit to come and make contributions and pay the fees to help us replenish those funds into keeping this plan going. All right? Thank you very much. Dr. Blanc, back to you. You've seem like you're getting very uneasy, but I'm coming back to you now on the question of the surge. We've seen the surge in COVID in August, and it must have been a challenge for you as the head of medical services, and certainly matron as well. How have you managed during the recent upsurge in COVID cases? What initiatives have been taken to manage positive cases and continue to promote patient safety here at the hospital?
Yes, Dr. James, very, very timely question. As you mentioned, COVID has put quite a bit of stress on pretty much all areas of the hospital, very much on the human resource. The first thing we had to do, obviously, was to repurpose space, certain buildings, to create both quarantine space and isolation space. So obviously if a patient is found to be positive or admitted and they're positive, then they would need to be isolated. If there is the query whether they have COVID or not, while we await results to confirm that, they would be in the quarantine unit. And of course, we had to develop operating procedures and protocols to run those new areas. The second initiative that we undertook was the testing of all patients coming into the accident and emergency department. And as we discussed previously, we've seen in excess of 14,000 patients coming in through the year, so it's a fairly busy department. And we found that the testing initiative, where we test the patients in A&E, has been very, very useful and beneficial. If we were to just take 1 month in terms of the figures that we looked at, September, which was probably where we peaked in terms of patients coming in, we saw almost 2,000 patients during that month. And we saw just over, of that 2,000, we had 100 cases, just over 100 cases that were positive. You can well imagine if we did not do that testing, so to speak, at the gate of the institution, and those patients were allowed onto the open wards, the kind of disaster we would have been looking at, because we would then have entire wards where one patient would infect another and would infect another, and essentially we would have a hospital of COVID. And because of this initiative, we've been able to prevent that, for most part, from happening. Yes, some people in the public will say, but I hear it had COVID on this one and I hear it had COVID on that ward. And that is true. We've had a few cases that, well, I guess some persons may want to use the term slip through, but that really may not even be the case. There is an incubation period for COVID, and sometimes patients are tested when they come in, they're negative. But we have put something in place that we test again all patients who are with us 5 days later. And we do pick up a small number of patients who then show signs of active infection. And of course, we take the necessary steps. We do the necessary contact tracing, both among the patients who were on the ward with that index patient, as well as the staff who interacted with that patient to ensure that there was not the disease being transmitted. In addition, all other patients coming in from all other avenues into the hospital, they have to be tested. So our outpatient clinics, we've reopened them again. We had to put in place the need for, well, put in place the antigen testing. Your patients have to be tested at not more than 2 days before their clinic visits. They will actually not be allowed into the clinic if they do not show proof of a negative antigen test. All patients coming in for non-emergency procedures, surgeries, etc., also have to come in with their tests. And that way, with the fact that we're testing pretty much everybody coming in, we've been able, I believe, to be quite successful in managing the influx of COVID into, in an uncontrolled way into the hospital. We've also taken a number of other measures. We'll probably, or persons in the public would have heard about our staff testing initiative, which was launched on the 1st of December. So as we go along, we'll provide more information to them on that. All members of staff have been trained, especially staff in direct patient contact, in the use of personal protective equipment so that they can protect themselves and protect other patients from COVID. We strongly encourage and make provisions for mask wearing, sanitization of services, hand hygiene, and physical distancing among staff and patients. Matron went through in some detail the no visitation policy, and again, we want to emphasize that it's in place not to make people's lives miserable, but simply to keep the compound as safe as possible for both staff and patients. Staff have been told repeatedly that if you're sick, you don't come to work. Go get tested, and we will, if necessary, help to manage you after we have a test, knowing what your status is. We will also have a bit of discourse on the staff vaccination program, because again, that is yet another initiative, all geared towards keeping here as safe as possible for both staff and patients.
Well, again, commendation to you. There are facilities in this part of the world that theaters haven't opened back because they're still very much overwhelmed with the number of positivities at the facilities. So the mere fact that we've been able to open back and have outpatient clinics in operation and our theaters are now operating fairly normal, but with safeguards, speak to the measures that have been put in place and have borne fruit for us over time. And I think that should not be underestimated because it took a bit of effort. And I can vouch for that. A lot of man hours to repurpose buildings and the protocols. And I have to say, you know, the public has really been supportive of the measures. We get data on, for instance, patients who present to our outpatient clinics, and religiously they have come with a test and in some cases volunteering the vaccination status. So the public has been very, very, very supportive of the initiatives over the last year, and they too have to be commended as partnering us in getting here thus far. But you raised the issue a while ago on the vaccination piece, and I want to switch to Matron now because We launched a Know Your Status campaign in August, and that was followed up by a staff vaccination drive in September. I sort of, Mitchell, want to share with us sort of before and after. You know, what happened when we did the Know Your Status program? What was the state of play in terms of antigen status of our staff and the vaccination status of our staff? And after we launched the vaccination drive and some other measures, what was the situation afterwards?
I guess everyone here is a bit excited to hear because we know what the public expect. We as nurses and hospital workers, well, everybody expects us to get vaccinated. So we initiated a Know Your Status for all members of staff, from doctors, nurses, warded, domestic staff, and we had a number of persons coming in to get tested. I think that's where we started. Sorry.
That's correct. Thank you.
No.
Just focus on this
Okay.
one.
We had a number of persons coming in to get vaccinated. We had a first phase and we had a second phase. So far, we have had a total of 616 persons coming in. However, I must say that even we had our own drive, we had persons, we asked persons who got vaccinated from outside to come in, and they would let us know with proper proof that they were vaccinated. We also initiated our own vaccination drive here at the Dominica China Friendship Hospital, where vaccines would be offered to our staff members on compound. And so far, with phase 1, we had 179 persons, and phase 2, we had 235. And those who were partially vaccinated, we had 17. So you notice that the population is 616. But you notice that the fully vaccinated, we moved from 179 to 235 in phase 2. And the partially vaccinated, we moved from 17 to 20. You look at 616 as a small figure, but we look at it as we have made progress. And even as we sit here, we are very proud. As you can see, you have our little badges, and we go about and we continue encouraging persons to come on to get vaccinated. Our badge it looks pretty, and I think everybody here maybe need a little badge on their chest, you know. And we continue to educate our staff. We continue, the departmental nurses, as they go about, they continue to tell the staff to get vaccinated. And I must say, some persons ask us, where you get that pretty badge? We tell them, come and get vaccinated, you know. So it's a very good measure for us here. And I want to say the hospital is a safe place to be. And although some persons are not vaccinated, what you find, persons are very careful. And as Dr. Blas said, if staff members, they feel sick or whatever, they are not feeling well, they voluntarily go down to A&E to get their antigen test done.
Right, so while there has been, from the data itself, while there has been an absolute increase in the level of vaccination and partially vaccinated from phase 1 to phase 2, the data is still showing that doctors are around 70%, our ward aides and orderlies somewhere around mid-40s, But the concern still is that our nurses are hedging somewhere around 30%, 35%, around 35%. From your take, what is causing this hesitancy among our nursing staff? Even though we've seen an increase over time, but when you look at the percentages in terms of the total staff, we're still seeing somewhere around 35%. What is causing this hesitancy?
As we go around, we speak with persons, Dr. James, and there's nothing really. We educate, and all we do is educate. Some persons will just say, period, I don't want to be vaccinated. But we cannot just leave it as that. We just have to keep on educating. And I think some persons will come on board. They will come on board because we will not give up. We will not give up.
Yeah, we have the Lunch and Learn series that we've been running over the last 3-4 months to try to encourage staff to get vaccinated. So while the vaccination program itself, we were to pick up about 42, I think, new persons came on board. 43. We still are uncomfortable with the levels of vaccination among healthcare workers in a general sense, but perhaps more importantly among our nursing staff. So we have a lot more work to do in that area to try to ramp up the numbers.
Even Dr. James, even as you said, hesitancy with the nursing staff, I'm proud to tell you that with our own vaccination drive here, we had about 13 nurses coming on board. We had about 13.
All right. Dripping tap, but nevertheless, a level of improvement. We have to do a lot more to ramp up the numbers. Thanks, Michan, for that update. I want to switch back to engineering, and there's been a lot of conversation on the Marigot Hospital. Could you update us on the state of development, the state of readiness for receiving patients at the hospital?
Sure. I'm happy to report the Marigot Hospital, it's well on its way to being complete. I would say it's about 80% complete, that is the building itself. Even though it's a smaller facility, a smaller hospital, it's very much going to be outfitted with resources to be a modern hospital as well. And I will just go through the physical layout and what you can expect at the Marigot Hospital. So the Marigot Hospital will have 3 floors: the basement, the ground floor, first floor, and each floor will be accessible by 2 staircases and 2 elevators. The basement will have staff accommodation for 6 beds, so we'll be able to accommodate staff who have to work for extended hours or staff who have to be on call. The basement will also have a health promotion unit, a chapel, and also we'll have our support services, engineering services for water storage, a generator, a pump room, also the oxygen bank, and you'll also have the medical stores and also a staff lounge as well. I'm going to move to the ground floor. So the ground floor is where we start serving the patients and the public. The ground floor is where you'll have the main reception area with administration, administrative offices, so the people who run the hospital will have the offices there. We have the accidents and emergency department, which opens to the ambulance. We have 3 delivery rooms. We'll also have an area dental clinic with 2 dental chairs, dialysis area, so persons who live in the Northeast will not have to come to DCFH to get dialysis services. They can now go to Marigot. We'll have the laboratory, where we'll have blood works and laboratory services, a pharmacy at the hospital as well, and the doctor's consultation room, so we'll also have an outpatient clinic at that hospital. And other services, the mortuary, biomedical waste, disposal facilities, and also a conference room. So the Marigot Hospital will also be an area where you can have conference and meetings. We'll also have radiology x-ray at that hospital. So like I said, it will also be outfitted with modern services. So a lot of services available for healthcare at the Marigot Hospital. Then we move to the first floor. This is where we have the inpatient wards. So we'll have the male wards for 13 beds, the female wards, 15 beds, and also a children's ward as well. The Marigot Hospital will also have an operating theater, 2 operating rooms to be exact, with recovery beds for persons recovering from surgery. We also have an ICU with 6 beds, and we'll also have 2 isolation rooms. The first floor will also have emergency dialysis and 2 private rooms. And of course, with all of these services on the first floor, with the operating theater and the wards, you must have sterilization services. So that will be on that floor, that exact floor. So in terms of the structure, the completion of the structure, the first floor, the ground floor, it is complete, only awaiting furniture and equipment. And the basement, we're still doing construction on the basement, so that's why I said that the building is about 80% complete, because we still have some construction to do in the basement. And also the outside of the facility, we have to do the pavement and the landscaping, so that is where we are with the Marigot Hospital. I see it coming to fruition in good time.
It's a really beautiful facility.
Yes.
I consider it really like a multi-purpose facility. It's like day and night. There's the ambulatory side, you know, that deals with dentistry and dialysis, etc. Then you have the emergency department, and then the inpatients building on the floor. Really, really. You have a sense of when the basement will be completed?
This basement, from the last visit, they said it might be done by end of January, February.
February.
Yes.
Yes, so our board is well ahead of the game. It was only last week we had a meeting with the staff who were the former hospital to get their views. And the chair of the clinical committee has mandated that within early in the new year, we intend to have a town hall meeting to invite the constituents of the area so that we could discuss. Because, you know, this is the people's facility, and therefore they have a say in how the services are implemented, how we phase it. They may not always agree with us, but certainly we have to give them an opportunity to tell us how they would like to see this facility implemented. Yeah, so good work. So let me switch back to quality. Based on the complaints that you've received, what are the top 5 complaints and incidents you have for you've captured in your database?
Well, Dr. James, to be honest, I find no joy, absolutely no joy in speaking about.
But Christmas is a joyous time, so why is that?
The complaints that patients are speaking about, and so I have to be honest with you, and I can tell you about 65% of the complaints has to do with clinical issues and interpersonal issues. So when I say interpersonal issues, I mean patients complain about the way the caregivers speak to them. Not so much as what the caregivers say, but how they speak with them. And so they may not like how a caregiver speak to them. So these are some of the interpersonal issues. When I speak about the clinical issue, I'm talking about prevention and treatment of ulcers. I've been told, Mrs. Hogan, my father came in with not one bed sore. But by the time he left, he had a few bed sores. And so persons are concerned about the treatment and management of pressure ulcers. Persons are also concerned about the plan of care. You know, when they discharge, the discharge plan. I've had a young lady call me and ask me, but what is MOPD? I'm looking at his discharge note. I don't know what is MOPD. I don't know what medication my father is on, and those kinds of things. So what we see is that we don't have sometimes, our caregivers, we don't spend enough time speaking to our patients. So it begs the question, what can we do about our admissions process, right? Do we have to do a better assessment when our patient comes? Assess them for the risk of falls, assess them for the risk of developing pressure ulcers. We have to think about that. We also have to look at implementing mandatory training for our staff. When we talk about training, we're talking about conflict resolution. We're talking about values and ethics in healthcare. We're talking about customer service in healthcare. So these are things that we we have to speak about. We also have to think about enforcing our ward rounds policy, right? So you know, a lot of work to be done, plenty work to be done. But Rome wasn't built in a day, Dr. James, and we will get there. We're getting there, and
So that conversation should be directed at 9 o'clock as the crow flies straight across here. They're the ones who have to address that. But I'm happy you're raising it because those complaints really is at the root of some of the serious concerns that the public have. And therefore, both Dr. Blair and Matron going to have to now address that in the plans and programs in 2022. We have to find a way of ensuring that when patients get into our gate, we understand what the skin condition is. Because the blame game is going to start. Did you get a ulcer at the hospital, or did you come in with the ulcer? We got to protect ourselves. So you got to put in place a photographic policy so we're able to protect ourselves firstly, and to be able to manage that. So those are quality improvement programs and initiatives that we hope to address in 2022. So thanks for that, Ms. Hogan.
Okay, Dr. James, you've asked us many questions, so it's time for you to jump into the fight as well. So recently, as everybody would have been aware, the hospital again was under the microscope, and concerns were being raised about access to care. So, sir, can you highlight what has been done to address this issue?
Yeah, that's an interesting one. Let me address the access from the most recent concern that has been brought to the table on the request for a patient to pay was $6.50, I believe it was. We did an investigation around it, and what I found out was that there's a formulary out of the Ministry of Health for drugs that are available to the hospital. So any what is called non-formulary drugs that are not on that approved listing, it is expected that patients pay for those medications. So for instance, if a patient goes to the imaging department for a CT with contrast, the expectation is that the patient go to central medical stores, pay for the contrast, and then come back to the department. So you could very well imagine if the patient is unable to pay, what will happen to that patient? We'll never see them again. So that is really a blatant violation of access to care because of one's inability to pay. So we had some long conversations with the manager of Central Medical Stores, and what is going before the board is, for consideration, is that they're going to give us those non-formulary drugs on consignment, both A&E as well as the imaging department. And on a monthly basis, they would check to see how much of those non-formulary items were utilized, and then they would bill the hospital for what was used. In that way, our caregivers, our doctors, our nurses do not have to saddle themselves with concerns around payments. Their concern is predominantly about providing care to patients. So the question of staff in A&E collecting $6.50 and is no longer going to be part of the overall arrangement. We're going to address it, and care is going to be provided to those patients, and then the ward class is going to bill those patients subsequently. We're not exonerating them or forgiving them for the debt, but at the moment where someone is in the most vulnerable state, where they're not able to pay for services, it is very irresponsible of us to be speaking to payment. Our responsibility is to provide care to the patient, and then the bill will follow them thereafter. All right, so this is one of the key areas that we're going to address to make sure that this issue of access is no longer an issue at the hospital. Our responsibility is to provide care to the patients, and if they're unable to pay, then the invoice will follow them once they're discharged. Okay.
I'm very sure the public will be happy to hear this, Dr. James.
I'm sure as well. All right, so let's wind up this segment by getting into looking at some expanded range of services that we've provided to the population. Again, expanded access. I know we've put in place some affiliation agreements with third parties outside for specialized care that we do not have here. Just highlight quickly, Doc, what were some of those agreements and the benefits they've brought to bear on for Dominican patients.
Right, so those relationships that you speak of are extremely important to our patients because they essentially help us, as you mentioned, to provide increased or expanded services, especially at tertiary care level. We, government, recently signed an agreement with the World Pediatric Project, WPP, and they provide health care primarily to the pediatric population, the children. We've benefited quite a bit from the relationship with them from, when we look at figures from 2001, we see that our children who were seen in Dominica or at the clinics they hold throughout the region, we had about 311 children, and the estimated cost of the care was over $6.7 million US. We also see that we had children being sent out, usually to the US, for care that couldn't be provided in Dominica or at the various centers in the region. And we had 22 such children, and primarily they would have been referred for surgeries in areas such as orthopedics, repair of cleft palates, etc. And the cost of the care was in excess of $4.7 million US. So again, money speaks, and you see that is and hopefully will remain an extremely valuable relationship that we have. We also very recently signed, me again, the ministry, with the Brenda Strafford Foundation. And again, this is a foundation that for a number of years have contributed in different areas, but primarily in eye care. They've assisted in training of staff. They've assisted very much in provision of equipment to be used in the eye clinic. And we can look forward to accessing over $1 million worth of EC, of equipment. As you would know, we have a new eye unit with its own operating theater. And so we are very excited about being able to properly equip this unit. And we will talk about centers for excellence in a little bit, and it will then become clear why it is so important that this unit is properly equipped. Very recently, the London School of Hygiene and Tropical Medicine collaborated with our eye team, and they completed a study in artificial intelligence being used in the diagnosis of diabetic retinopathy. And I'm very sure we will do a special press conference or release so that the public knows of this work, because it's an extremely valuable piece of scientific work, which really has a lot of good implications for provision of eye care in Dominica, specifically in the area of managing diabetic retinopathy. And I mean, most people would know that the London School of Hygiene is a top-rated institution. I should say we're also in discussions with the University Hospital in Martinique in terms of settling on an MOU. Again, the public would be aware that Martinique is one of our primary referral areas, and we already have a relationship with the institution there. What we're looking to do is to properly formalize it, which will then make it easier for patients to access care at that institution. There's also the My Heart, Your Heart program, which deals with the placement of pacemakers. And again, we're looking at the studies, and we are in discussion of the possibility of having that program started at this hospital. And so those are just about 4, probably the top, most obvious, and most advanced in terms of discussions. But you would be very much aware there are a number of other discussions, probably in earlier phases, that, of course, as they begin to mature and hopefully bear some fruit, we will share with the public.
Yeah, thank you. With 7 operating theaters, we have enough capacity now to start bringing our surgeons here to do high-end procedures. And that is a possibility for us as well. All right, so before we get into the commitments for 2022, in spite of all the achievements you've shared with us today, there must have been quite a number of challenges encountered during the year. I will give each of you 2 minutes, only 2 minutes, to highlight the major challenges encountered in each area. Let's start with direct patient care.
Well, the first statement I made was that it has been a very challenging year. And if I begin to take up the 2 minutes, it might stretch into 2 hours and 2 days. However, I would just really like to highlight 3 points, but it's by no means the only 3 challenges that we faced. As I mentioned before, it has been very difficult providing care in the context of the COVID pandemic and all of what that means, as well as the fact that we're still doing construction on the site. There's still a lot of instability, moving around, having to put stopgap measures in place, and that has been very stressful, very difficult, and I'm telling you, we look forward very, very much to the completion of the project. We would have discussed the unnecessary admissions to accident and emergency, and that is something that we have to address because we are also aware that a number of the complaints that come in, not all, but a number of the complaints that come in from patients who spend an extended period of time in A&E, and partly because they really were not true emergencies. And we have to begin to think of how we process those patients if indeed they come to us for care. And we've had significant staffing shortages. They already existed before COVID, but COVID made it even more difficult because we also had to assist in providing medical staff to the COVID care unit in Portsmouth. And that has been an ongoing battle in terms of how we continue to provide efficient, effective, safe care with significant staff limitations.
Thank you. Vitran?
I must say that one of the major challenges, as Dr. Blair said, is with our nursing staff. We are very, very short. It was an existing problem before, and it is even worse because we had to deploy nursing staff to the COVID unit in Portsmouth. What you find, we have a very high, because the nurses work with extended hours, we have seen an increase in absenteeism and our sickness profile. Nurses, they often complain of burnout, and this is a major, major concern for us here at the Dominica China Friendship Hospital. However, I must say, regardless of the limited amount of staff we are still able to provide quality patient care. And that is one of the things that we want the public to know, that despite our nursing shortage, we can still provide care to our patients. And I want to commend the nurses for their hard work. And we look forward, maybe one day it will solve. We don't know how long COVID will last. But we just have to do what we have to do.
Yeah. Well, tell me something. Apart from the deployment of nursing staff to support the Portsmouth operations, are you seeing any attrition related to resignations?
Yes, Dr. James. We have a few over the past months. We have seen a few nurses, well, I must say, resign from the service, and most of them, should I say, I am not sure whether it is because of COVID, and it is kind of affecting our nursing staff here. Migration and nursing staff shortage, yes, it is affecting.
Yeah, that's a big challenge, yeah. Because it then affects quality of care going forward. Well, let me switch to engineering. I know you've just joined us, but what are the challenges you face right now?
All right. So the repercussions of COVID-19, it did not exclude engineering services at all. We all know that the nature of the disease is one that is harsh on the respiratory system in its full-blown form. And so that means that the engineering department, we now had to increase our production of oxygen and our filling of oxygen tanks to supply the COVID facility and still maintain the supply at the Dominica China Friendship Hospital. Unfortunately, our oxygen filling plant sustained some damage from Hurricane Maria, and it hasn't been operating at its optimum. So therefore, this has put a strain on that equipment and even a strain on the department to fulfill the obligations to provide the oxygen during these pandemic times. Another challenge that we have is we inherited a number of outdated preventative maintenance contracts. And since they were outdated, this led to a lot of downtime, a lot of our equipment being unable to operate. And that led to the lack of services for the patients, lack of available services to the doctors who need the equipment such as the X-ray, the mammography for diagnosis, and to create plans of treatment. So, and when we take stock of these preventative maintenance contracts, looking at them, the cost comes up to about $400,000 for preventative maintenance contract. That's because this equipment, they're specialized equipment that you and I, we're not certified to go and to check them. They have to be certified by the manufacturer. So that's why there's such costly contracts. So that was a challenge that we had to take stock of these contracts and see what we can do to get them up to date and to bring back up the services or radiology services. So these are the two major challenges that we've had in engineering.
400,000 US, that is over 1 million
EC dollars, yes.
Where are you going to get the funds to fix that? I don't have it, so how
Well, Dr.
how are you
James,
going to do it?
to echo what you said, we've never denied access. If you need an X-ray, if you need a CT scan and you're unable to pay, and if you need the CT scan, we still allow persons to come and get their scans. However, we're still urging in anything that you can contribute. Once you're billed for the CT scan, you can come to us and see how you can make payment for those services. Because we really do need the payment. And if the payments go to making sure that the equipment runs to serve you, to serve me, to serve all of us, and to help the doctors to do their jobs in a more efficient way, to provide the necessary medical treatment that we all need.
Thank you. Thank you very much for that. Quality?
Well, Dr. James, one of our major challenges is the underreporting of incidents. We already spoke of the number of incidents that we received for the year, routine incidents, 163, and we're actually supposed to be recording well in excess of 2,000 incidents. So many are afraid to report, and we just want to remind persons that we are creating a just culture for reporting, and we're not meting out punitive measures. We just want to know what happened, why it happened, and learn from it. And so I'm urging the public to give us a fair chance to try to fix those systematic errors. Again, we cannot fix without criticism.
All right. Thank you very much. Facilities?
An area of concern for me is the high level of absenteeism, and the matron has already alluded to that. High level of absenteeism means loss of production. It also affects the delivery of service. And it puts an extra strain on staff who has to take up the slacks. It disrupts services, and sometimes it is stressful or challenging because we have to replace, find substitutes. Sometimes the periods are too short, and therefore it puts a strain on us. We have collated some data across the board on absenteeism, and we intend to put a dollar value to it so that the institution can know, how much it is costing them because of the absenteeism. We intend as well to research to find out why our absenteeism is so high, and with a view of fixing or doing what we need to do to get staff, to encourage staff to report to work. And I just want to pause to tell them, when you take a day off, just by simply taking a day off, it is affecting your colleague, because your colleague have to take up the slack and sometimes have to put extra hours to get the work done.
Yeah, the absenteeism piece is something we have to address to find out why. Is it abuse, or is it that our staff are really ill? If it is the latter, then we'll work with the board in putting some kind of wellness program in place. But, loss of productive hours, and I'm sort of waiting to hear what the value of that is. In a human services organization, really doesn't speak well for sustaining the services, right? And so I commend you for taking that initiative, and hopefully by the turn of the year, I want to see across all areas how many hours we've lost, put a value to it, and then perhaps we could decide on a strategy going forward. But the absenteeism is really troubling.
Yes, it is.
Yeah. All right, so let's move into the last segment of this review, looking at our commitments, plans, and programs for 2022. Next year, the board has given us a mandate to refocus our attention around improving the patient care experience. Some refer to it as a patient-centered care model. Such a model will require a redesign in the way clinical and support services are delivered. I would like each of you to highlight some of the significant changes that the public can expect to see implemented during the year. Dr. Barr?
Okay, Dr. James. We commit to the phased commissioning of the Marigot Hospital. Mrs. Laville spent some time informing us of the exciting developments there, and we look forward to providing medical services in a well-run, functional institution. We also commit to the implementation of a minor cases unit in A&E with a view to reduce waiting times for non-urgent cases. As we mentioned before, up to 70% of patients coming into A&E are really not urgent cases, are really not true emergencies. However, they will come, and so we are mandated to provide care to them. So we kind of want to do a fast tracking of those patients, if you know, to use that term, where we would have staff really dedicated to seeing only those patients. So you come, it's not very severe, you receive your care, and you're able to return home in a short space of time. We also hope to provide psychosocial support to all patients, particularly those with traumatic situations. We know that health cannot be viewed as only physical, and when patients come in with, yes, physical issues, but with attendant or associated psychological, mental issues, we want to recognize them and provide all of the necessary support that they will need so that not just their physical self becomes better, but their mental and emotional self also receives care. We are hoping to develop centers for excellence, primarily in eye care and the imaging services. We have a very unique opportunity with ophthalmology services. We have an entire unit just for eye, with its own theater, and really the possibilities are endless. We can provide improved services not just for local persons, but also for the region. It will be such a wonderful thing to hear persons coming into Dominica to receive care rather than Dominicans having to leave here to go out for care. We also see those possibilities existing with the radiology, imaging department, radiology department. And if people are paying close attention, they would recognize once everything is complete, the unit will have essentially all of the major modalities that any hospital in a developed country will have. And so again, we have really a unique opportunity to make this a top-of-the-line, top-class service that persons will come to Dominica just to get service at that unit. And finally, we are hoping, it's a process that has started, to complete the process of seeking accreditation of the hospital medical's internship program. Once a program is accredited, it means it's received international recognition by an association or body that is responsible for that. And it then puts your program, so to speak, on international stage. It gives value to your program, and so it attracts now persons to the program. It attracts universities, etc., and again, a whole host of positive possibilities open up if we were to attain accreditation.
I'm happy to hear that the minor cases unit will fast track those non-emergent cases and therefore reduce waiting time. But any time frame on when the accreditation piece, the accreditation of the hospital for internship, any